Hello, everybody. This is Miss Benita, and this is hopefully as quick as possible a review on some key points of the musculoskeletal system. These are the chapters that information can be found in your Lewis Med Surg book, chapter 62 and 63. It's also chapter 60 in this Orange Saunders book, edition number 8. So you can find that information there as well. Hopefully you can see my screen, and hopefully this is recording. All right, and I did send this particular PowerPoint out to you previously, and it is the one that always says _ my notes after it, because it's the one that I use to speak from. So just again, quick overview: soft tissue injuries, sprains and strains, dislocations, subluxations, sports-related injuries such as, or overuse injuries such as rotator cuff tears, meniscus injuries, and anterior cruciate ligament tears or ACLs. I'm just looking at some of my notes down here at the bottom, and just to bring to your attention, dislocations and subluxations, which there are pictures of these things again on your books that I'll have you go back and refer to. But it's very dangerous with those injuries if they are not put back into place. They usually do that without surgery and just do a closed reduction of that, or put back in place of that dislocation or subluxation. But it can, when it becomes out of joint, it can push on nerve and or blood vessels, and it can cause compartmental syndromes and neurovascular injuries and decreased circulation to that entire limb. So it is very important that these are treated as soon as possible, within hours. Another condition you might want to be familiar with is called avascular necrosis, and that usually happens in the larger joint of the hip. But again, it is when there is some sort of injury or swelling or inflammation, something like that, that is causing over time some kind of occlusion or pressure to the neurovascular vessels in that area. And sometimes hip replacements are mostly done for osteoarthritis, but sometimes they have to be done because avascular necrosis has occurred in the hip area. Rotator cuff injuries, just a key point on those is they want those patients to start therapy, physical therapy, within 24 hours after the surgery, even if it's not extremely challenging. It could be very simple things that they do, but if you don't start to move a shoulder joint, it can become what's called frozen, and then they have to go back in and actually kind of injure it again and repair it. Shoulders in general can be very painful for a short period of time. Abduction pillows and slings help to keep that joint from moving, which can help decrease that pain. And you can get injections also into those joints. Meniscus injuries and ACL injuries. Most of those types of injuries, like a rotator cuff tear, actually, all of those can be treated with outpatient surgery using scopes, usually. So meniscus and ACLs in the knee, those are called arthroscopies. And after those surgeries, obviously outpatient surgery, the patient does have to be NPO for a certain amount of hours or after midnight. They do have to stop anticoagulation, and all the different surgical rules would apply to these patients. They do use general anesthesia for those surgeries, and the ACLs tend to take a little longer than the meniscus, because sometimes repairing a tear or even using donor ligament, sometimes those can get a little involved. But then most of those surgeries are only in the hour, maybe 2 hour range. The patients can then wake up in the PACU and in the outpatient surgery observation area, and they can usually go home within 24 hours. So once they're home, the acronym RICE will apply to those types of surgeries. These individuals will have restricted activity. You do not get them up and moving. They just had surgery on a cartilage or a ligament and it needs to heal in there first. Sometimes they're no weight bearing. They're on crutches and things like that. When they do get up, but you want to keep the extremity elevated up above the heart, and you want to apply ice 20 minutes on several times a day. So the compression doesn't really apply here, but the rest of the RICE, rest, ice, compression, elevation, the rest of it does apply to these kinds of surgeries. It looks like in my notes down here at the bottom, I've given you some page numbers and some pictures where you can go to look at pictures. All right, so again, soft tissue injuries, acute care is the RICE, stopping the activity, limiting the movement, using the ice for the first day or two, 20 to 30 minutes at a time. When you find questions that say ice continually, that answer is not correct. You might have done that at home, but that's not what you're supposed to do. It's not what we would do in the hospital. When compression is used, remember it is applied distally at the bottom and you go up toward the heart, you elevate. And analgesia, these types of surgeries do not and should not be requiring opiates. They should require NSAIDs, Tylenol, those types of analgesic agents. If these patients need more than that, if their pain is increasing, that is actually something you should call and report to a physician. They should not need, again, more than mild analgesics, and increased pain would not be expected for these procedures, especially if they're in a chair resting, staying off of it. Okay, again, it looks like I have a table here for emergency management of acute soft tissue injuries and a page you can look at in the Lewis Med Surg book. I do have included on this PowerPoint the picture of a normal joint, a dislocation, and a subluxation. So as you can see, the subluxation is total separation, whereas a dislocation is not. Just a picture of an immobilizer. A lot of the knee surgeries may, or even some fractures may have some kind of an immobilizing brace on like this, or splint, I guess you would call it, to keep the knee from bending and straightening and bending and straightening it. You don't want all that movement going on that extremity while it heals. Fractures. Again, this is just a review. I don't have time for a 3-hour lecture or whatever with you that I hope you've already had some of, and you have to go back into your books, find these pictures and these pages and or videos that you like to use, and just review all this kind of material. I have some page numbers and some tables listed for you there to look and review different types of fractures, how fractures heal, symptoms of fractures, and which ones are most concerning and why. Obviously, an open fracture is much more concerning than some of the others because you have the increased risk of infection, and infection into the area and into the bone, which is infection of the bone is called osteomyelitis. And since bones are very deep in, it's middle of our body or skeleton, they are very hard to get rid of infections. The deeper the infection is internally. Immobility, fractures in general will have some degree, especially of the legs, of immobility, but even the arms, you will be immobile, with eating and dressing and things in which you use those extremities for. Just realize that some of the main These are not like priority complications, but some complications that patients with fractures can experience that we try to initiate different nursing interventions to prevent. These are constipation, renal stones, and skin integrity issues. Again, with constipation, you can go back to your knowledge on that, increasing fiber and fluids, using stool softeners. A lot of patients with fractures might be on opiates. Their pain may be a little bit more severe than soft tissue injuries, and those can cause constipation as well. So most of those patients should be on some kind of a stool softener so they don't get impacted. You wouldn't want that on top of having a fracture. Renal stones, again, immobility. They really need to increase their fluids, even though it makes them have to get up and go to the restroom or whatever. It still needs to be done to help these patients to prevent renal stones while they're immobile. Skin integrity, obviously, in positioning these patients. Frequently, even little small adjustments will matter. Assessing their skin underneath, looking, avoiding wrinkles in their sheets, anything like that is going to be very important for those types of patients. A lot of, if they're able to use their arms, then overhead trapeze on the bed comes in very handy because they can use their like good leg and the trapeze to lift up and down. And but obviously, if there's any problem with the arms, or sometimes some of the elderly are not able to use those kinds of things. Again, fractures, what we do for them. The first thing you want to do when you suspect a fracture is to immobilize it. Immobilize it before you assess it, and that would be the answer on most of the questions that you're going to run into. If you immobilize the joint, it can help decrease the risk of compartmental syndrome or any neurovascular injuries if you're not moving that broken leg, knee, wrist, thigh, whatever, around. You want to keep it totally immobile. Fractures can be treated by what they call closed reduction or open reduction. Closed reduction would require IV sedation. So sometimes something can be manipulated by a trained physician and the bone be put back together without any kind of incision or a shoulder or an arm or something. But obviously that's going to hurt really bad. So we're going to give some IV sedation. There's a lot of casting, traction, and splints used after closed reductions, but the only difference really is that they don't have this open incision, which increases their risk of infection. So closed reductions can be done in the ED, again, with IV sedation of some sort. Open reductions, ORIFs, open reduction internal fixation. So open reductions of a fracture, any kind of orthopedic injury would involve an incision. These are inpatient surgeries. They don't keep most of them over 1 to 3 days anymore. But remember the scope surgeries, there are arthroscopies, shoulder, knee, whatever, hip, whatever. Arthroscopies are outpatient surgeries that are kept less than 24 hours. They will have less pain involved and less anesthetic on board because their surgery isn't as long. But these open reductions, internal fixations, they have an incision to repair the area, and they usually use screws or plates or bolts or whatever all they use, but they have some kind of internal fixation where they screw and plate the bone back together again. They can use surgical anesthetic complications, obviously. These surgeries can be over 2 hours long. Again, they'd have to stay in the hospital. They're going to be immobile. They're the highest risk for DVTs, pulmonary embolisms, And another thing called bad embolisms are orthopedic patients and orthopedic surgery. They are the most at risk of any surgery to get those kinds of complications. So we are constantly assessing them for that. CAS. There is a couple pages there and a table listed for you there. Let's see here. But off the top of my head, some of the things I've seen asked about or that has come up with conversation is the fact that you don't, like, they can get itchy underneath the cast and you don't put anything down in there to scratch because you could get a wound in there. So you can use a blow dryer on a low setting and blow it down through there. When they're first put a plaster cast on, you don't want to hold it with your fingers. You want to hold it in the palm of your hand because your fingers kind of at the joints, they can bend and cause little dents in the cast, and those dents can then push on those areas of skin under the cast. So you want to hold a cast while it is still wet. You want it to lay on a pillow or lay flat and use the palm of your hands, not the fingers. A lot of casts, plaster casts cannot get wet. But a lot of casts these days are fiberglass casts, and those are able to get wet, I understand. Keep the cast and extremity elevated. It takes 24 to 72 hours for a wet plaster cast to dry. Turn the extremity every 1 or 2 hours if possible. We talked about the hair dryer. I'm reading off of page 875 in the Saunders book. Monitor for signs of infection such as increased temperature, hot spots on the cast, bowel outer. By the way, you can put ice on the cast in the area that's hurting or over the fracture part. That ice or coldness can go all the way through and provide some comfort. Okay, well, that's all I can think of with casts. I'll let you guys do the rest of the research on that. Traction. There is skin traction. There is skeletal traction or external fixation traction. All right, so I want to make sure you guys understand that Buck's traction is a skin traction. There are pictures of these things in Saunders on 874, but these pages and figures here are from the Med-Surg book. When we have a hip fracture, we use Buck's traction. We wrap this device around their leg. It has pulleys attached to it, in which you can attach weight, and it pulls that leg. That hip fracture is usually shorter than the other leg, and it's usually externally rotated. So we can take it, put that around, and we pull it out straight. And if you can do that, it immobilizes that joint area in the hip, and again, can prevent any kind of neurovascular injuries. It also helps prevent spasm. And how would you evaluate if Buck's traction is working? The patient will be more comfortable. Skin assessments every 2 to 4 hours. You can release and look under that thing that we wrap around their leg. The pulleys and the weights should hang freely and not be on the floor or up against the bed or anything like that. Okay, skeletal traction is when they put actual pins through a joint, through a bone, and then they apply pulley and weight to it, and they're actually pulling it with these external fixations. You would think it'd be very painful, but actually it helps. It helps to reduce the fracture and again, to decrease spasms in the area. We do have to do pin care around the sites when they have these skeletal tractions, and it's changed over the years. Sorry, I haven't kept up with the best practice, but I'm gonna just refer you to your books for that. It used to be a sterile procedure. Not sure that it is anymore, but whatever we touch the pin site with, we usually keep that a Q-tip or whatever sterile on the end of it. Okay. Oh, this is a picture of Buck's traction. It is skin traction. You usually have questions on your exit HESI and NCLEX about Buck's traction. And I've had students do the HESI and they come back to me and say, I didn't know that was skin traction. I'm like, well, okay. But you should listen to this. You should listen to other videos. I can't imagine this not being mentioned. And or if you do any kind of reading assignments, it should have been in there. So you should know that Buck's traction is a type of skin traction. This is external skeletal. So she's got probably pins here, and you can see that they're attached and pulling that down. This is an internal fixation where they have nails and screws that have, kind of holding a bone back together again. So just be familiar with all those different types of modalities that they use. Oh, here's some cast care stuff for you. I'll let you read that yourself. Oh, these are what you remember. Most ortho questions, I always go for this neurovascular assessment stuff first, because most of them are about that. And I think that I have a slide on that specifically coming up. This is what you want to do before when you have a cast on. And this is what you do not want to do. What would be most dangerous or worst with all these casts is if you suspect any kind of decreased neurovascular circulation or something. This is just a mention of some very specific types of fractures. And I think you can read over those yourself, but a Colles fracture is the radius ulnar to the wrist. That is a very common fracture for those greater than 50 years old. I think my mother had one of these, but when the elderly fall, they usually, if they fall forward, they catch themselves with their wrists and their wrists will break. Hip fractures. I should try to look that up and be very familiar with the symptoms, what you need to assess for, complications of hip fractures and the Buck's traction and all of that. Mandible fractures. When jaws are fractured, we usually wire them shut while they heal. These patients are very high risk for airway issues. I had a patient once whose jaw was fired and they were throwing up about every 2 hours. And he just had to lean forward. And I know that sounds kind of harsh, but he just had to let it kind of all fall out, get out. But you can see if he couldn't lean forward, how dangerous that could be. So you always must have wire cutters at these patients' bedways. Airway and suctioning equipment needs to be available. They need a really meticulous oral care. And yeah, try to medicate for nausea. So what's my most important thing with mandible fractures? And by the way, if I have a hip fracture, a mandible fracture, a Colles fracture, who do I see first? You see the jaw fracture. You see the one that's going to cause airway issues first. Amputations, phantom pain. They still have pain like their leg is there. That is a very real phenomenon. We do medicate for it. We also do things called mirror therapy, where we let the patient look at the fact that the leg is not there. There's something connection that has to be done in the brain to realize that the leg is no longer there. You do elevate amputations the first 24 hours. After that, you want to avoid pillows and keep it straight to avoid contractions. vertebral fractures. These are back spinal fractures. They don't always all cause nerve compression, but obviously that would be a very important thing to be looking for as a neurovascular assessment in the legs. But while these patients have a fracture, they're usually on, have a body brace on. They wear just a cotton t-shirt under it. You log roll these patients. You want to monitor for incontinence and report it immediately, especially if the patient is not usually incontinent, because it can indicate that there is pressure on the lower part of the cord. Right. Drugs, medication, pharmacology for musculoskeletal. I just want to mention to you guys central and peripheral muscle relaxants. These are the names of some of the more common ones that are used. These patients all need tetanus, DPT boosters, and bone penetrating antibiotics such as cephalosporins. So if patients are on any of these peripheral muscle relaxers, remember we have to educate them that these drugs may cause drowsiness. They are not supposed to drive or operate heavy machinery while on these medications. That could be a big safety risk. All right, so this one is in red for a reason. I want to catch your attention. Our neurovascular assessment, I have a page number listed there for you, but this is where all those priority questions with musculoskeletal kind of end up. When patients are complaining of these vascular symptoms, that's what you want to see first, and or these neurological symptoms. And it's 5 or 1, 2, 3, 4, 5, 6. Oh, I've got pressure added here. It's like, wait a minute, I know my 5 P's, but these are 6. So feeling of pressure, I guess. I don't know. Got these from a book, I'm sure. So there you have it. Complications, musculoskeletal complications. Again, these are a list of all of them, but if I was to ask you which one is most dangerous, which one would you see first, you would have to go with the airway breathing issue, which would be a fat embolism or a pulmonary embolism. After that, you would have to go with the compartment syndrome because you can lose life and or limb, and that's who you see first. After that, we would look and want to monitor for and possibly treat DVTs, rhabdo, and infections. Those are the later things that might develop and not as quickly life-threatening as some of the others that are listed here. You do need to know the signs and symptoms of pulmonary and fat embolisms. You do get asked about those a lot on exams and even select all that apply questions. I have a list here in my notes, but you could find them in your book as well. Chest pain, tachypnea, cyanosis, dyspnea, apprehension, feeling of doom, tachycardia, hypoxemia, changes in mental status. You would have a low blood pressure, if any problem with the blood pressure at all. These are like shock kind of states. The big difference between pulmonary and fat embolism is that the fat embolisms can also have petechial rashes in the buccal or mucous membranes, eyes, neck, chest, axilla in that area. O2 would definitely be something, oxygen therapy, and it might be on a non-rebreather mask at 100% for those kinds of conditions are going to be emergencies. If they don't get extremely fast care, they can develop into complete respiratory failures and damage and things like that. So you always want to be listening to these patients' lungs, getting them to cough and deep breathe, and always know about DVTs because they can become pulmonary embolisms. And then again, fat embolisms. You just have to be aware that that can happen with any kind of musculoskeletal injury. It's usually 24 to 48 hours after the injury. It's pretty soon after. And so you really want to keep your eye out for that kind of thing happening. Compartmental syndrome, 6 Ps. If they start to get extreme swelling that is compromising their neurovascular system, they do a procedure called a fasciotomy. And it is actually just using a scalpel and just making a big slice down the extremity to relieve the pressure. We don't elevate compartment syndromes. They don't have blood supply. Remember, things that don't have blood supply, you keep down. Hopefully you guys are familiar with rhabdomyolysis. If not, I'm going to refer you back to review that or reach out and I'll be glad to explain it to you. All right, let's try some of these questions. Plaster splint is applied with an elastic bandage to the leg of a patient with a fractured tibia in preparation for open reduction and internal fixation. So I always stop right there at that period and get that picture of that patient in my mind and realize that is my patient. I am the nurse of this patient. Okay, so they've got it immobilized with some kind of splint and they wrapped it up and we're waiting for surgery. Okay, the patient reports increasing pain in the affected leg and foot that is not relieved by loosening the elastic bandage. The first action of the nurse is to A, elevate the leg on 2 pillows, B, notify the healthcare provider, C, apply an ice bag over the fracture site, or D, perform a neurovascular assessment of the foot. I'm going to let you guys have a moment for that one. And increasing pain can indicate neurovascular compromise. I would have loosened the bandage like that first, and the next thing I would do would be D, perform a neurovascular assessment of the foot to see exactly what it is that I'm looking at. I might need to do B, I might need to do something else, but first I want to assess this situation because I don't know for sure unless I have the exact symptoms to report to the healthcare provider. All right. I don't even have the answer there. Okay. A patient has a severely sprained ankle from a sports injury. What should the nurse teach the patient prior to discharge from the urgent care center? Apply cold and heat for 30 minutes until symptoms are relieved. B, apply cold for 20 to 30 minutes with breaks of 10 to 15 minutes during the first 2 days. C, use continuous cold for the first 24 hours and continuous heat for that until the symptoms are relieved. Or D, apply continuous heat to the ankle for the first 24 hours and continuous cold. Okay, I told you already, don't pick anything with continuous. So let's rule out C and D and out of A and B. B is the best answer. All righty. Okay, so those are kind of acute musculoskeletal things. I didn't go over knee and joint replacements with you during this review. It is not included on your exam number 2. However, I would definitely review knee and hip replacements and the care after those before you take your exit HESI. And I can even do a little review with you guys if you would like me to. Just reach out, make an appointment, and we'll get her done. Okay, these are some other musculoskeletal problems. And by the way, everything I'm talking about on this review could be included in your Unit 2 exam, but also good review for your exit and other exams as well, but is not all encompassing. Again, and remember, the book always trumps anything I say. So a lot of times teachers speak from a clinical perspective. the book is always correct. So it's never a you said thing. And if you don't understand something, go to your book to clarify, or a resource, not Google, or reach out to me and we'll get an answer for you. All right, bone cancer. One type of bone cancer you may get asked about is myeloma, multiple myeloma. And these types of cancers are extremely painful, extremely painful. Poor prognosis once you get cancer in the bone area, whether it be primary or a secondary metastasis. These patients are usually somewhat immobile. When patients are immobile, when we don't walk on our feet, we are always at risk for hypercalcemia. So it doesn't matter if it's bone cancer or something else. When you're on long-term bed rest, you are at risk for hypercalcemia. Remember, with hypercalcemia, the symptoms go down. You have decreased tendon reflexes or flaccid and relaxed muscle activity. These patients can get out of bed. They can be assisted to a chair, possibly walk to a bathroom or whatever, but you do need to be very careful with them and support their extremities, like around their waist. Don't pull at them. They are at risks for very easily to be fractured. Okay. Some key points about osteoporosis. Who's at risk for osteoporosis? Signs and symptoms. I'm going to let you look all of that up. But menopausal women are very high risk for osteoporosis. Also, low calcium diets. Smoking has been highly correlated with osteoporosis. Alcohol use of steroids, some diuretics can contribute to osteoporosis, long-term daily anti-diuretics, anti-seizure medication can all contribute to the development of osteoporosis. Biphosphonates. So this is a medication, aka alendronate. Do I have that anywhere? Okay, it's spelled ALENDRONATE, alendronate. Is a biphosphonate that can be taken and used to treat osteoporosis. These patients must drink this drug with a full glass of water 30 minutes before a meal, usually before breakfast, and they have to be able to sit upright, not 30 degrees, but upright for at least 30 minutes. Just to get the point across, I understand that if this stuff goes back, refluxes, it can burn a hole in your esophagus. So you want it to go in the stomach and stay there. Some of the side effects there are listed. Another drug that you want to be familiar with for this exam is calcitonin. When patients have low serum calcium levels, we can treat them with calcitonin, but the drug, from what I understand, it actually pulls calcium from the bone to get it into the serum and get our serum calciums up. So when it's pulling the calcium from the bone, it can actually contribute to osteoporosis, osteomalacia, and some of those kinds of things. So don't think because someone's taking calcitonin, it's calcium supplement. It's not. It's different. So please refer to your farm stuff and review that drug as well. Back and neck pain. Okay, acute back pain. Acute back pain, obviously we as nurses are at risk for back injuries. You should learn how to use proper body mechanics. You should put beds up when you're working on patients. You should bend and use your knees and hips and not your back. However, it's very painful. I've had them where I can't even take a deep breath for a week or two because it hurts every time I take a breath, and the muscles in my back, kind of expand, and that alone can cause pain. But I want to tell you that those acute pain symptoms do get better. So we don't want to go and reach for all the opiates right away. So we do try to use the muscle relaxants and the NSAIDs to help with this acute back pain while these patients have very limited mobility. And then you need to be familiar as nurses on how to prevent these kinds of back injuries and how to educate others to do so as well. No prone positioning when patients have acute back pain. Chronic back pain is acute pain that has lasted for greater than 3 months. We really try to get these individuals involved in braces and supports and in physical therapy. The exercise will be lifelong. If you have an injury that is going to always be there, not really heal to a degree where you have no pain. In other words, probably not just soft tissue pain, but vertebral fractures and those kinds of things. Those patients have to realize as soon as you stop doing your therapy or your exercise, your pain can increase again. So it is very much and highly emphasized that they continue their exercise for life. Enter vertebral disc disease. Conservative therapies, it can involve all of these different classes of medications, as well as epidural corticosteroid injections into the disc areas. But if that doesn't work, then a more aggressive type of treatment would be actual spinal surgery. Opiates are used for 24 to 48 hours with patient-controlled analgesia. We do try to get these patients off of that, especially these days, as soon as possible. We switch from IV to oral drugs as soon as the patient is tolerating food and liquids. We want them to be on muscle relaxants to decrease the amount of opioids they might need. And we can also add things like a neuropathic pain, Neurontin, gabapentin, and we could maybe do the opioid at noon and then do gabapentin at muscle relaxer at 2, and then alternate things, using positioning, doing things like that, but trying to avoid opiates if possible. Again, monitoring for GI and bowel function post-surgical for anyone, but especially spinal injuries for paralytic ileus, which would be no bowel sounds, and constipation, making sure these patients have stool softeners prescribed, and possibly even laxatives as needed. They may have trouble with their bladder emptying, and they might need straight catheterization, not an indwelling catheter, but straight cathed at times. And you would again notify a surgeon immediately if bowel or bladder incontinence occurs or starts to occur, because it can indicate nerve damage. Okay, let me see if I got anything else here for you guys. Gout. You just want to be familiar. It's that gout is an inflammatory condition, and it involves increased uric acid levels that are greater than 9. When patients have gout, they are put on that low purine diet, the no organ meat, shellfish, red meat, etc. Same diet as we spoke of with the uric acid kidney stones. Also, in the Med-Surg book, let's see here, chapter 61, it has the assessment of the musculoskeletal system. Just be familiar with all of the different types of medical terminology that's listed there. And then on page 1440 in my book, it starts talking to you about a lot of different types of diagnostic studies that can be done involving the musculoskeletal system. Pay a special attention, know what a EMG is. Let's see here. Oh, there it is. An EMG. I just want you to realize I had this done once. It was extremely uncomfortable, but they actually used these like, it was like acupuncture needles or something. And they went and stabbed me. I mean, from my fingers all the way to my nose and from my toes all the way up to my hip. I mean, just trying to, and then they put electrical current through that needle, which is hooked to a wire in this little machine of theirs. And they want to know, and they measure your muscular activity related to that. And I mean, I never found that the findings were very conclusive, but my insurance company wanted me to have that done before I got an MRI or CAT scan approved, so I did. But just that a patient realizes that there is some discomfort, that it does involve needles, and you want to assist all those little needle sites to make sure they don't form any kind of hematoma or inflammation of any kind. And then I know on page 1442, it has the arthroscopy mentioned there as well, so you might want to look at that too. All right, I think that'll set you up pretty well to as a review and to be able to be successful on any questions that might be asked on your unit exam. This is, again, not all encompassing, and there's a lot more that you would need to review before your exit HESI exam week 9. If you guys have questions about anything, please let me know. It's been a pleasure. I'll get this out to you, and I'll be recording these every time I have a free hour, and I will be getting them all out to you this week. All right. Thank you.